Good afternoon, everyone. I welcome each and every one of you for this webinar by Dr. Revathi S. Rajan, Bangalore. And today the topic is periconceptional risk modulation in ART pregnancies. So I welcome Dr. Rajan to the presentation.
Thank you.
To you, Dr.
Thank you so much, BSV, Bharat Serums, for giving me this wonderful on there to convert that we start working as an extended inverted pyramid and not just at the time of conception or beyond. So if you have to optimize the chances of conception and a take-home baby, it is very important that we look at the periconceptional risk factors, that is factors that can complicate conception and pregnancy just prior to conception itself, and then risk modulate. So the topic for today is periconceptional risk modulation in ART pregnancies. I work as a senior consultant, maternal fetal medicine and managing director at Mirror Health, Bengaluru. I'm a maternal fetal medicine specialist. So my chief areas of interest have been high-risk pregnancies, more so hypertensive disorders in pregnancy. So the introduction is to emphasize the role of an extended inverted pyramid of prenatal care. So gone are those days where women used to come less frequently during the first and the second trimesters, and all the major visits happened in the third trimester. Now we not only expect the women to come earlier, more so in the first trimester, we also would want them to come much earlier, even before conception, not just in ART conception, even otherwise to plan a pregnancy, because this is going to add value with respect to risk modulation. And the focus is always on early pregnancy units, because there are certain unique problems, like, for instance, threatened abortions. There can be issues like ectopic pregnancy. There can be, bleeding, which is nothing but threatened abortions. There can be problems like spontaneous losses and things like that, which are very common in high-risk pregnancies. And most of these ART conceptions are high-risk pregnancies beyond doubt. So we need dedicated staff who can identify this much early before it complicates into a pregnancy wastage. So the goal is to optimize obstetric outcomes in all, including those undergoing ART with no previous obstetric experience. And this is something that I would want to emphasize, because in natural conceptions or women who've come to you with a previous experience, you already have something to talk about. Like if you have had a woman with recurrent pregnancy loss or somebody who's had medical disorders but had got pregnant, you at least can learn certain things from her previous pregnancy experience. But in most of these patients who conceive after ART, they usually, they would have conceived for the first time. So we have very little to actually bank on, and we have to make sure that these pregnancies go on smoothly. So we have to be very, very vigilant in our surveillance protocols. Now, moving to the next important concept, we need to understand the background. See, all pregnancy outcomes could be influenced by a complex interaction at the maternal-fetal interface, reflected as challenges and countered by adaptive mechanisms. So pregnancy is always treated as a foreign body, like an allograft, and so there is always a sense of rejection by the body, and this is actually encountered as challenges, which may reflect as subchorionic hemorrhages and those kinds of things. And usually the body adapts itself in optimized situations to accept the pregnancy. So anticipation and surveillance for these perceived challenges with incorporation of appropriate risk modulation strategies is the key that would contribute to better fertility and pregnancy outcomes. So everything depends on how prophylactic we could get, how we could probably identify what could be a probable issue, and modify it as per the most recent evidence and guidelines so that we can reduce or minimize the chances of pregnancy wastage. So we all know there's always oxidative stress. So you have the reactive oxygen species causing inflammation. And, we always have process of detoxification and restoration, which can probably, reduce or minimize the oxidative stress. So in case the process of detoxification and restoration has not been done optimally, there is the problem where the reactive oxygen species can bounce back and cause more inflammation, and which can probably result in a bad obstetric outcome. Now, prediction of this oxidative stress using biomarkers is not standardized. See, how do you, oxidative stress is a diffuse, it's a very, very, what do you call it? It could be anything. It's a very general nomenclature. It could be because of medical problems. It could be because medical problems in the sense it could be thrombophilia, it could be diabetes, it could be hypertension, it could be anything. And it could be infection. And we don't have specific biomarkers or a single biomarker, because this is, again, a compendium of so many risk factors. And we really don't have a single marker to say, yes, this lady is optimally, things are all right. And, she's the ideal state, she's in the ideal state for us to, take her forward through ART and pregnancy. So we have to identify, these probable risk factors and also interventions to counter oxidative stress. So that is what is being researched right now. It's very complex, not that we can map everything 100%, but what we'll have to do is identify at least most of these that can contribute to stress, and also identify restorative strategies that can probably minimize the degree of oxidative stress. And we have to understand what is called the immune regulation in pregnancy. Now, we all know that the placenta, which is the organ in between the maternal and the fetal, which is, in between the mother and the fetus, is placed in the maternal fetal interface. And this is a complex unit with regulatory factors. It allows for immune tolerance, facilitating progression of pregnancy. So basically, if the placenta is well formed, then, the pregnancy can proceed more smoothly, and definitely, the outcomes can be optimized. So at the level of implantation, you have infiltration of syncytial trophoblasts into the endometrium, which is the endocrine organ coordinating maternal adaptive responses, and differentiation of the trophectoderm to form cytotrophoblasts. So basically, we have to move backwards and say, we should work from the time of implantation, where you have the infiltration of the syncytial trophoblasts into the endometrium. And, later, there is differentiation of the trophectoderm into cytotrophoblasts, resulting in an embryo, which then grows. And then we have the placenta, which starts forming at around 8 weeks of gestation. And this probably acts, or contributes to most of the immune tolerance. Now, I'm introducing all these concepts because, it's only with these concepts that we could probably, talk, forward. So basically, you have to understand the immunology. Just a minute. Let me just come back to this. Yeah, the immune regulation in pregnancy. So we've talked about the placenta. Now, what is very, very important is the fetus as an allograft. So most of the times it can happen that pregnancy contributes to a lot of inflammatory and immune suppressive responses. And this ultimately results in the acceptance of the fetal allograft. So it is very, very important that the trophoblasts that are actually formed or multiplying, they are very, very crucial to result in a fetal allograft survival. So these trophoblasts are resistant to the natural killer cells and lymphocyte activated cells, and this defines the feto-placental interface. So they also express NK cell type FC gamma receptor 3 for phagocytosis, plus immunosuppressive factors like TGF beta. So because these trophoblasts can produce certain molecular factors which can probably suppress the immunological rejection of the fetal allograft can move forward, growing effectively into an embryo and the fetus. Now, there are certain terms at the molecular level which is often confusing. A lot of clinicians don't know what to do. They are not, clearly defined. They don't know whether that can actually affect, pregnancy and outcomes. So, coming to the natural killer cells, we know that malfunction of the natural killer cells is attributed to infertility and recurrent miscarriages. They're usually identified by CD56, which is usually present in the uterus as well as mostly concentrated in the implantation site. In close contact with invading trophoblastic cells, the exact role in immunomodulated responses are not proven, but peripheral NK cells have been misassumed to be similar to NK cells. Therapies directed to suppress peripheral NK cells have no proven value. So what I would want to communicate here is these factors could cause oxidative stress at the molecular level. And this is something that we have to bear in mind from the implantation times. And here, what is very, very important is that these NK cells, which probably can affect immunomodulation with respect to pregnancy outcomes, are only at the level of the uterus and at the implantation site. We cannot measure their responses, or they're not directly proportional to the responses of the NK cells, which are actually found in the peripheral blood. And so if we are giving therapies to neutralize these unwanted NK cell responses that are happening from the periphery, may not be of proven value. Please understand this, because most of these patients who are autoimmune are infertile and they have this problem with NK cells, but looking at them in the peripheral blood may not be really prognostic of what's going to happen at implantation and what's going to happen through pregnancy. Next, we have what's actually referred to as the anti-nuclear antibody status, or the ANA. And we know that anti-nuclear antibodies are a group of antibodies that are directed against nuclear and nucleolar proteins of the biological cell. ANA is classically associated with systemic lupus erythematosus, but can be positive in other autoimmune disorders and some elderly individuals. Clinical correlation with seropositivity is essential to make a working diagnosis, because you might have lots of these infertile women who are positive for ANA. At the same time, you might have a lot of asymptomatic women who are positive for ANA. So it cannot be tested in all patients, but definitely you need to correlate clinically, identify those segments of women who have a predisposing autoimmune factor, like for instance, a systemic disease like SLE, or those women who've had bad obstetric outcomes where a positivity may actually mean some autoimmune trigger, which could probably cause more oxidative stress. Slide is stuck. So, okay. The next important thing that we have to understand, that evidence has shown that ANA positivity could influence implantation failures in vitro fertilization, intracytoplasmic sperm injection, or the ICSI cycles, especially those in the first treatment cycle, have shown a positive correlation with ANA positivity. However, this does not influence cumulative pregnancy rate without treatment. So what is very, very important is, yes, there has been some evidence that ANA positivity could influence implantation, but if you're looking at the cumulative pregnancy rate, there has not been enough evidence to say that, yes, it is contributory to pregnancy rates. It was concluded that medications directed for the treatment of seropositive status would favor better implantation rates, especially to those in the first treatment cycle. So if you're looking at those patients with autoimmune triggers, those who've been identified to be ANA positive, if treated, they've had better outcomes, better implantation rates, better pregnancy outcomes, is what the evidence is. Antinuclear antibody positivity has also been shown to be associated with unexplained recurrent pregnancy loss and also predicted unfavorable obstetric outcomes. So you have to understand that there is a definite discretion on behalf of the clinician that you cannot be testing antinuclear antibody on every individual. You're going to test it in those with an autoimmune background who are infertile, or those with previous obstetric outcomes, maybe with secondary infertility, or those who have not conceived, with an suspected autoimmune trigger for antinuclear antibody. And in case they are positive, definitely by treating them, you would reduce the lead time that is required for them to conceive during an ART cycle. And at the same time, you will be optimizing their outcomes in case they've had situations like biochemical pregnancies or recurrent pregnancy loss and have had secondary infertility, and you use ART to let them conceive. If you have to optimize outcomes, you have to continue treating or immunomodulating them even after they have conceived. Now, anti-nuclear antibody is to be, but what is very important is that you cannot just simply like that measure antinuclear antibody. If you really want to correlate with clinical outcomes, it has to be measured through the immunofluorescence technique, because ELISA, though it offers a high degree of sensitivity, has low specificity and cannot be used as a screening test. Structured and bigger studies are needed to prove the influence of ANA positivity on fertility and pregnancy. So any inflammatory trigger in the body can initiate a hostile autoimmune response, which can cause unfavorable conditions for conception. So it is important that any challenge to make an accurate diagnosis of autoimmune conditions that could complicate fertility and pregnancy has to be taken as a priority, especially in a surveillance clinic. So measuring specific biochemical parameters reflective of the various organ systems of the body to map inflammatory responses could be an indirect method to measure hostile autoimmune responses. So what we're trying to say is, see, most of these things, especially the NK cells or the ANA, now these are all, playing around autoimmune responses. So you could have two kinds of individuals: some individuals who have diffuse autoimmune problems who have not conceived, or those individuals who have not conceived because they've had some local inflammatory trigger. That's what I'm trying to say, which has probably, exaggerated the process of fetal allograft rejection, or probably not even caused implantation. So in these individuals, they usually benefit by looking at inflammatory markers, and these inflammatory markers could be specific biochemical parameters, which I'm going to probably come in the next slide, which when properly immunomodulated could definitely augment the process of implantation and conception. Now, what are these inflammatory markers? Derangement of basic blood profiles like complete blood count. You have the total count, you have the ESR. So in these individuals, the total count could be high. There could be marginally raised ESR. There could be abnormal metabolic profiles, that is the SGOT, SGPT could be deranged. Acute phase reactants like the C-reactive protein, etc., could be deranged. And this could suggest a diffuse inflammatory process which is triggered by an autoimmune etiology. Parameters like elevated ESR could be non-specific, and it may vary with disease intensity. Normalization of this parameter could be appreciated only after a while following the resolution of the inflammatory process. So you could get indirect evidences by looking at the ESR, by looking at the total count, by looking at the CRP, by looking at the liver enzymes, or maybe the creat. Step up immunological studies or serologies, flow cytometry, HLA typing, etc. may also yield inconclusive results for making a diagnosis. Hence, basic and advanced testing, if suspicious of a defined autoimmune condition, together with clinical suspicion, would add value in making a comprehensive clinical diagnosis. So what I'm trying to say is, if you have an infertile couple who probably has to, where you need to do an ART, it's important to identify whether there are some autoimmune conditions. See, I'm talking about those factors which are not very explicit. So in case you have an autoimmune response, you have to first map whether this lady has a systemic autoimmune condition or it's just an inflammatory trigger which needs to be suppressed. Sometimes it could be both. So this clarity will help us for better immunomodulating this individual before this individual undergoes ART, so that the fetal allograft is well accepted and the pregnancy progresses well. So, but you cannot extrapolate this to all individuals. Very, very important is to understand this individual clearly, both clinically as well as biochemically, before we move on to investigating further. Now, the next important parameter that I would want to emphasize is on the C-reactive protein. It's an immune protein which is generated in the body and participates in defense against provoked antigens by opsonization and triggering the complement system. If the C-reactive protein in the blood is very high, it could reflect as an exaggerated inflammatory response triggered by a hostile autoimmune process. A value of CRP less than 0.2 milligrams per deciliter is considered to be normal, and any value more than 1 milligram per deciliter could imply inflammation in the general population. So it's basically anything that can actually trigger inflammation, and this is marked by the C-reactive protein. Now, how do we understand what are those cutoff levels during pregnancy, and how do we actually call it that there is a challenge or an inflammation that's ongoing? So if it's in the first trimester, we still don't have established cutoffs. However, a value of more than 5 milligrams per deciliter, we use the same cutoff even for periconception levels, has been known to be associated with low birth weight babies and neonatal complications. Second trimester, we usually use a cutoff of 0.4 to 20.3 milligrams per deciliter. Third trimester, we usually use a cutoff of 0.4 to 8.1 milligrams per deciliter. Prednisolone and hydroxychloroquine are drugs both classified as FDA category C that have been used extensively for immunomodulation during the periconceptional period and beyond. So what I would want to say is, if you have found that there is an exaggerated inflammatory process which is manifested either by a raised C-reactive protein or the basic metabolic profile, which is actually deranged in terms of inflammation, then what is done to suppress is use hydroxychloroquine and prednisolone in the most rationalistic way, and both of them are FDA category C. It's recommended for the clinician to explain with clarity the benefits of immunomodulation as against the probable risks before drug administration. So it's beyond the scope of this talk to specifically tell you exactly the doses, but what I'm trying to tell you is definitely identify those women who are prone to such inflammatory responses and immunomodulate them with hydroxychloroquine or prednisolone or both if needed. It's definitely a challenge to make an accurate laboratory diagnosis of autoimmune disease, which continues to remain so even in the periconceptional period. A battery of tests, including basic laboratory investigations, metabolic panel, acute phase reactants like the C-reactive protein, may add value apart from advanced immunological studies, serologies, and HLA typing. So it's very, very important to look at these reports, which are commonly performed, like a CBC, looking at the total count, looking at the ESR, looking at the creat, looking at the LFT for transaminases, and looking at the C-reactive protein. These are very simple tests, and this can probably tell you who are these women who have exaggerated inflammatory responses. And thereafter, depending on what the clinical features suggest, you can look at identify those women with diffuse autoimmune issues, which are probably confronting them to get pregnant. Application of clinical criteria and qualifying a particular disease state prior to testing significantly increases the sensitivity for diagnosis of autoimmune diseases. Now, next comes, so we finished with the NK cells, we did the anti-nuclear antibody, we actually looked at the CRP, and we also looked at the basic metabolic profile. Now, if you're looking at another very important antibody, which is least spoken about and many people don't know how to use it, is the thyroid peroxidase antibody. High levels of thyroid peroxidase antibody and high TSHs have negative effect on IVF and embryo transfer in terms of embryo quality and abortion rates. There has been an increased association of TPO antibody positivity with endometriosis, as the latter is known to coexist with other autoimmune conditions. There has also been a similar association of polycystic ovarian syndrome, or PCOS. So this has been attributable to the increased estrogen to progesterone ratio usually seen in PCOS. So what is important to understand is whether it is endometriosis or PCOS or TPO antibody, most of these are autoimmune processes by themselves. So you can have either all of them together or you can have one or two in combinations, but this can definitely affect or have a bearing on their fertility and pregnancy experiences. Now, what is the effect on pregnancy? Thyroid hormone is considered essential for normal placentation. Evidence has shown that preeclampsia, preterm delivery, fetal growth restriction could be attributable to defective early placentation. And these effects are worsened in women with TPO positivity with thyroid dysfunction. A recent study that has also shown that TPO positive hypothyroid women are also more to mid-trimester abortions compared to those who are hypothyroid and TPO negative. So it just does not influence the implantation. It can go much beyond. It can cause mid-trimester abortions. It can cause bad placentation, hypertension, preterm birth. So you can have a whole lot of problems. A recent prospective study, which was performed at a tertiary care center for fertility and high-risk pregnancy in South India between August 2013 to September 2015, where outcomes of pregnancy in women with TPO positivity were mapped after appropriate dose adjustments of thyroxine, concluded that there was a trend towards decrease in mid-trimester abortions in these women. And I was the principal investigator, and was published in 2016. So a positive TPO antibody test was diagnosed when the levels were equal or more than 35 international units per ml, a TSH level of more than or equal to 2.5 milli international units at booking in the first trimester was included under this category. So we looked at all women who had a level of more than 2.5, and we took a positive TPO positive test as somebody with a value of 35 international units per ml. Overt hypothyroid pregnant women who were already on thyroxine supplements were also included. Dose adjustments were made aggressive to 2 micrograms per kg body weight. So we looked at these levels of, anybody who was TSH, who had a high value of TSH, were repeated the test every 4 to 6 weeks. And we tried to adjust the dose so that ultimately everyone received somewhere between 1 to 2 micrograms per kg body weight till the TSH normalized. So what you have to understand is a TPO positivity will only reflect as a high level of TSH, a fluctuating level of TSH, more frequently fluctuating level of TSH. So what you have to do actually is to normalize the levels. There's no role in treating them with steroids or hexaquares just because they are an autoimmune process, unless and until they are associated with other autoimmune conditions. And you have to understand that these levels have to be taken into serious consideration. In the first trimester, we take a level of 0.1 to 2.5 milli international units per ml as normal of TSH. Second trimester, we take a level of 0.2 to 3 milli international units per ml. And in the third trimester, we take a level of 0.3 to 3 milli-international units per ml. And what is important, this is only at the time of diagnosis, but ideally it is better to keep a TSH of less than 2.5. And if you have a lady who's TPO positive, to keep it less than 2. And that is mainly because they fluctuate quite a bit. About 76.5% of these women were all subclinically hypothyroid, and hence emphasize the need for appropriate surveillance and management of this cohort to avert adverse obstetric consequences. This is basically the nature of pregnancies that we actually monitored. We had all kinds of patients, those with gestational glucose intolerance, hyperhomocysteinemia, those with ANA positive status, those who had first trimester issues, second trimester abortions. So if you look at this, in this study, pregnant women with a TPO antibody level of more than 600 international units per ml was significantly associated with gestational hypertension and fetal growth restriction. This is very, very important. So how do the levels actually make an influence on the pregnancy? And significant associations were also found between pregnant women aged 30 years and older who were also TPO positive with hyperhomocysteinemia and APLA, or had bad obstetric history and recurrent pregnancy loss. So basically what you have to understand is TPO can definitely influence fertility, implantation, pregnancy outcomes. The only way that you can probably salvage these are to look at their TSH levels more closely and find out whether they are associated with a bigger autoimmune problem and treat it simultaneously. But when it comes to looking at TPO positive women with hypothyroidism, treat their hypothyroidism more efficiently. It could be subclinical. The next important concept that I'm going to elaborate is something that is spoken a lot, but most clinicians are confused as to what to do about them. So this is about homocysteine, which is a sulfur-containing amino acid synthesized in the body, and it's from an essential amino acid called methionine. Hyperhomocysteinemia is defined as levels of more than or equal to 50 micromoles per liter if you're looking at the general population. Levels decrease during pregnancy, attributable to hemodilution, increased glomerular filtration, along with increased utilization by the fetus, apart from the hormonal changes during pregnancy. But if you're looking at pregnancy, the level is actually 12 micromoles per liter, which is considered to be anything above more than that is considered to be hyperhomocysteinemia, unlike in the general population where we take a cutoff of 15. Hyperhomocysteinemia could be attributable for adverse outcomes both during pregnancy and beyond. Suboptimal methylation could result in recurrent miscarriages, fetal structural defects, preeclampsia, fetal growth restriction, preterm labor, and intrauterine fetal demises. High levels of homocysteine could also adversely influence IVF outcomes. This is mainly because it can worsen the oxidative stress. And attributable risks outside pregnancy include cardiovascular disease, vascular strokes, osteoporosis, and other neurodegenerative disorders. So what is important is homocysteine accumulates in the body when you don't. You can see that mechanism, which is actually displayed as part of the slide. Very, very important that that we have B6, B12, and folic acid for the proper metabolism of this homocysteine. Otherwise, this will accumulate as hyperhomocysteinemia and cause oxidative stress and bad outcomes. It's more commonly due to combined deficiencies of B6, B12, and folic acid in Southeast Asian population, unlike in the Caucasians, where it could be attributed to genetic mutations. 97 to 99% of the patients who come to us have only nutritional problems. They don't have genetic mutations. So there's no point in testing for genetic mutations in our population. The test is highly labile and needs standardization. So you need to do a fasting ethylene diamine tetraacetic acid test, or the EDTA sample, which needs to be collected and centrifuged immediately. Values in early pregnancy are considered more reliable to predict adverse maternal and fetal outcomes. So you have to remember, if you want to measure homocysteine and find out whether it is causing oxidative stress, which could be because of a nutrition problem, do it early pregnancy, do it in the first trimester, do it on a fasting state, and look at a value of 12 micromoles per liter. A study which was conducted by Pradeep Chakravarti et al., Kolkata in 2013, has depicted hyperhomocysteinemia remained a significant risk factor in predicting pregnancy salvage rates in women with PCOS as obesity and insulin resistance control with other confounding factors. And this could be attributable to adverse pregnancy outcomes. So anticoagulation with low molecular weight heparin and ecosprin conferred an additional advantage in averting pregnancy wastage in those with hyperhomocysteinemia phenotype. So what I'm trying to say is definitely this could be associated in women with PCOS as well as obesity, but what can be done to improve, or to decrease pregnancy wastage is to support them with B6B12 folic acid and also with low molecular weight heparin and ecosprin, which they used in the first trimester until you could probably prognosticate with the uterine artery Doppler to optimize pregnancy outcomes. Another prospective study, which was conducted at a tertiary center for fertility and high-risk pregnancy in South India, enrolled about 442 pregnant women, and they were all screened universally for a year from September 2012 to August 2013, and this reported a high prevalence of 28%, of which 37% of the women were primary gravida. I was part of the study. The mean age of these women was 32, and the mean homocysteine level was 12.6 micromoles per liter. There was a strong positive correlation with ANA positivity and a trend towards a positive correlation with subclinical hypothyroidism. So we talked about homocysteine, and the next important concept that we need to understand, during the periconceptional period is a HbA1c. So this is also important. Evidence has shown that there is a significant risk of congenital malformations for a HbA1c value of 10.4%. However, the risk for pregnancy, adverse pregnancy outcomes increases with a HbA1c of more than 6.9%. Most studies recommend a pre-pregnancy HbA1c levels of less than 7% in women with type 1 diabetes, which further stresses the need for targeted preconceptional risk modulation. So you want to get it to less than 6 ideally, or at least less than 7 before they conceive. The next important concept is the in utero fetal programming. Very, very important. You've looked at so many factors. You've looked at autoimmunity, you've looked at the NK cells, you've looked at ANA, you've looked at metabolic profiles, which could trigger autoimmune responses, which could be triggered by autoimmune responses. We looked at C-reactive protein, we looked at TPO antibody, we looked at subclinical hypothyroidism and HbA1c. And so after looking at all this, we also have to monitor the fetus very, very well. That is because ultimately the fetus is going to be programmed in a hostile in utero fetal the in utero environment, then that can affect the organ cell, cause altered metabolic function, cause modified intracellular organization, result in organ malfunction. At the same time, it can affect the epigenetics. That means the genes may be structurally normal, looking normal, but they're functionally different. So you can have alterations resulting in affected DNA methylation, chromatin changes, altered gene expressions, and ultimately contribute to a fetus which may develop disease as it grows into an adult, or this may be attributable to fetal origin of adult disease. So very, very important that you program this fetus to be more healthy and more stronger to face the outside world. Otherwise, if it is not going to be programmed well, it's going to succumb to oxidative stress later. Now, the other important thing that I would want to emphasize is there a difference between IVF pregnancies versus non-IVF pregnancies? This was a study that recent studies have established that there is a possible difference in perinatal outcomes between pregnancies due to assisted reproductions and spontaneous conceptions, but this cannot be attributed to ART per se. Please understand, it's not because of the technique. It's because most of these have inherent risk factors. These mothers are either elderly, they have low priority risk factors, which are more common in this group of population, which can probably result in poor perinatal outcomes. There was a study that I conducted, in a tertiary center. We looked at 60 IVF ICSI conceptions versus non-IVF ICSI conceptions. And what we actually found out was there was no statistically significant P as far as the outcomes were concerned. But what was very, very significant is definitely the risk factors probably contributed to bad obstetric outcomes. Now, the key points of my discussion: evidence translated into practice. Surveillance for adverse outcomes as a consequence of dysfunctional placentation should be initiated during the peri-implantation phase. Extended inverted pyramid of prenatal care, shifting the focus too much earlier. So you have to probably start working peri-implantation. Predicting oxidative stress using biomarkers is still being researched, which could pave the way to pregnancy outcomes. So we don't really know what are the specific markers, but I did speak about some markers which can probably help you to mechanisms influence immune tolerance at the maternal-fetal interface, which involves effective angiogenesis and trophoblastic invasion. Placenta facilitates immune tolerance. Very, very important. That's the reason we have to concentrate on effective malformations have been attributed to infertility in RPL. However, peripheral NK cells do not deposit level of less than 7% preconceptionally is preferred for better outcomes in type 1 diabetes. Effective surveillance initiated periconceptionally for the identification of the probable risk factors could complicate pregnancy, which could complicate to adverse pregnancy outcomes, helps to avoid irreversible changes in the genome, aiding good in utero fetal programming. The perinatal outcomes of ART pregnancies do not differ significantly from non-ART pregnancies based on the mode of conception, and effective surveillance for risk factors in ART pregnancies could result in better perinatal outcomes. So these are my references. I'm also probably going to talk about some evidences to ponder. Does chronic endometritis and what could be the effect of chronic endometritis on ART conceptions? Progesterone supports during the luteal phase, subchorionic hematoma, recommendations for preconceptional counseling. Definitely, there has been some literature which says that chronic endometritis could contribute to RIF, and most of these are bacterial vaginosis and mycoplasma. So this is very important to be looked pre-conception as well as periconception and also during pregnancy to optimize outcomes. We've also had conclusions saying that vaginal administration was the preferred route for most of the luteal supports post-ART, but nowadays oral route administration has been gaining momentum. We need bigger studies to prove its efficacy. With frozen embryo transfers, yes, these supports have been extended up to 12 weeks, but in otherwise, we really do not know what is the need of continuing these estrogen and progesterone supports beyond 8 weeks because the placenta is already beginning to form, but however, it has to be dealt with clinically. And if you're looking at subchorionic hematoma, that reflects a challenge, that there is some problem between the maternal and the fetal interface, and very, very common in IVF pregnancies and frozen embryo transfer pregnancies, not only the more common in frozen embryo transfers, and very important that we identify the challenges, not just suppress it with progesterones. And what is important to understand is, though these factors may not grossly influence the live birth rates, but definitely the incidence of having preeclampsia, fetal growth restriction, preterm birth, and other issues, with the baby because of a defective placentation is more common in those with, who have had ARD and have had a subchorionic hematoma. That's the reason I'm actually stressing. And this is the recent recommendation which has come out from the ACOG bulletin in 2020. And this is very, very, this is again reaffirmed in 2020. And this is very, very important because what they're trying to say is you have to identify the perinatal risk that may be associated with ART, explain to the couple in detail, tell them about multifetal pregnancy before you actually start the process, keep them aware, tell them, identify all the medical risk factors which could probably contribute, for a bad fertility or a pregnancy pregnancy outcome, because it's not just about the uterus, the ovaries, and the tubes. It's much beyond this, and identify the systemic factors. Also identify those genetic conditions, because of which pregnancy has not happened in these individuals. Identify if there are any transmissible genetic factors. Please counsel them about higher order multiple pregnancies, the need for fetal reduction in case they actually conceive with higher order multiple gestations. And finally, what they have concluded is the use of ART has increased dramatically worldwide and has made pregnancy possible for many infertile couples. However, perinatal risks associated with any ART and ovulation induction pregnancy remain, and particularly in multifetal gestation, because it almost gets doubled. To promote optimal outcomes, obstetrician gynecologists and other healthcare providers should complete a thorough medical evaluation and address maternal health problems, which becomes the domain of a maternal fetal medicine specialist, or health conditions before initiating ART. Very, very important. Do not initiate ART without discretion. Identify the factors, map the patient well, and then only initiate ART for better outcomes. And when proceeding with ART, make every appropriate effort to achieve a singleton gestation, and patients should receive appropriate counseling about the risks associated with ART, especially risks associated with multiple pregnancy, and the option in such cases for multi-fetal reduction. Thank you so much. And I think I have covered most of these unforeseen challenges, or those difficult challenges which probably has, can contribute to difficult or challenging outcomes. So I'm open to questions, and I can take the questions.
Thank you so much, ma'am. Any questions for ma'am? You can just put it in the chat box, Q&A chat box. So, ma'am, we'll wait for some questions. If there are no questions, we'll conclude the session.
Sure. And what is very important is to identify all these factors, just not about, identifying the ideal time in terms of the oocyte quality, because all these can influence the gamete quality, the implantation, the endometrium, the implantation. So very, very important that we look at these molecular associations like the NK cells, the ANA positivity, the TPO positivity, the diffuse autoimmune problems, the sugar control, the thyroids, the genetics, which can all, if not properly risk modulated, lead to bad outcomes, especially in an ART conception. So very, very important that the clinician understands when to treat and when not to treat and how to treat. That's the whole idea of this talk.
Dr. Shilpa has some questions. Dr. Shilpa, I've unmuted you. You can talk. Hello?
Hello?
Dr. Shilpa? Hello? Dr. Shilpa, you can unmute yourself and speak. Hello? I think she's not responding. Nevertheless, madam, we'll then conclude the session in that case. On behalf
you can even email the questions if somebody wants to, and
yeah.
I can always look into it at a one-to-one level.
Sure. At this note, I would like to thank you, madam, on behalf of Bharat Serums and Vaccines for taking a webinar on this topic on our platform. Thank you so much, ma'am. I'll be sharing the recording with you shortly.
Sure.
Yeah. Okay. Thank you. Have a great day.
Thank you so much. Thanks.
Bye.
Bye.